Welcome, everyone. My name is Christy Bird McKeeve. I am the Executive Director of Butte-Glenn Medical Society and the CEO of Healthy Rural California. I'm also the GME Administrator as we try to launch a psychiatry residency in Northern Butte County. We were just speaking with the presenters about youth psychiatry and how important that is, and whatever we can do to bring more psychiatrists to Northern California is what we're doing. So today, though, is our virtual grand rounds. Butte-Glenn Medical Society celebrates our 75th anniversary, and we are pleased to have this presentation today. First, I just want to remind everybody, even though it's been a very long time that we've been in the virtual world, just please keep yourself muted unless you're speaking. The chat feature is a great way to sort of record your questions if the timing isn't quite right to unmute and speak. And then we are recording this presentation. It will be available on Butte-Glenn Medical Society's YouTube channel. And for technical difficulties, we find that it's just best to log off and sign back in, and that usually resolves the issue. Thank you to Enloe Medical Center for providing CME. Dora Anderson is here, and she will be the one facilitating that after the presentation. And then I'm pleased to introduce our chair of CME, Dr. Mandy Robertson, to introduce the presenters.
Yeah, and we're lucky today to have two pediatric cardiologists educate us on post-COVID effects of the post-COVID effects that may affect the heart and cardiac function for kids. And one of the reasons we decided to have or invite some people to speak to us and educate us is because we often do physical exams as part of the Scotty previous.
Yeah, I'm not.
We often do physical exams as part of screening for clearance for kids to return or to do athletics at schools. And we were getting feedback from a number of the physicians that do that, that they were a little bit concerned about what to do with kids that may have had COVID in clearing them to participate in sports. So that's really what led to us getting this talk put together. And so we have Dr. Ingrid Olson, who's a pediatric cardiologist at Stanford, as well as Dr. Elizabeth Profita today to talk to us about this topic. And I'm gonna actually, I was just gonna go ahead and move on to let them speak at this point. But you can see Dr. Ingrid Olson has been a pediatric cardiologist at Stanford for a while, and these are her areas of expertise. And the next slide, I think we have Dr. Elizabeth Profita, who's also a pediatric cardiologist, and these are some of her areas of expertise. So I'll go ahead and turn it over to them.
Great, let me just share my screen real quick. Okay. Okay, and can you guys see my slides? Great. Well, thank you guys so much for inviting Ingrid and myself to talk to you a little bit about COVID-19. We are not experts. We just, I think, both fell into roles here at Stanford of helping care for children and think about children who've had COVID infection. And so we're going to talk just a little bit about the cardiac involvement in patients, in pediatric patients who have COVID-19 infection. And we'll talk about both a little bit about MISC and COVID myocarditis. And then we'll discuss a little bit about the vaccine-associated myocarditis that we've been seeing and what our thoughts are on that. And then I'll pass it over to Dr. Olson to talk about what do we do after COVID infection and how do we help guide families and patients to safely return to play. Please feel free to ask any questions in the chat or let us know if anything's not clear. So myocarditis, you're probably familiar with. It is a condition of inflammation of the myocardium that's usually associated with dysfunction of the heart. The incidence is around 1 to 2 per 100,000. And we do see a lot of myocarditis in adolescents and then also sometimes in infancy. And there does seem to be a slight prevalence in males. It's almost always viral, and the pathogenesis of it is related to, excuse me, direct viral invasion of the myocardium that leads to both cell injury and necrosis. And also there's immune activation and T cell infiltration that can lead to very significant cardiac dysfunction. So some patients can present fairly asymptomatically, but it can lead all the way to decompensated heart failure and hemodynamic collapse and cardiogenic shock. Labs often show elevated inflammatory markers, troponin and BNP, and treatment is largely supportive. Often IVIG is used, and many of these children can recover with supportive measures. To make the diagnosis of myocarditis, the gold standard is by using cardiac biopsy, where we do a cardiac catheterization and we take a small piece of the RV septum. And it is not all that sensitive due to the fact that sometimes the infiltrates are patchy. This is a picture of histology just showing what the lymphocytic infiltrates look like in classic myocarditis. And there are generally accepted criteria, which are called the Dallas criteria, to define whether a biopsy meets criteria for myocarditis. But as we have developed cardiac MRI, we have increasingly been using that to avoid some of the complications and risks associated with cardiac caths in sick and unstable patients. And it is able to detect myocardial injury, edema, decreases in function. And so there are generally accepted criteria for cardiac MRI diagnosis of myocarditis that are called the Lake Louise criteria. So what we know in COVID-19 infection is that we know that the SARS-CoV-2 virus can cause direct myocardial injury, and SARS-CoV-2 has been found within myocytes. And it can enter the myocardial cells by binding to the ACE type 2 receptors that are on the cell surface. And this is one of the theories around why children may have been less susceptible to COVID-19 infection, as they typically have decreased function of the ACE2 type 2 receptors. And it may also lead to there is some theorizing around patients on ACE inhibitors or ARBs being at higher risk of infection, as that leads to overexpression of the ACE type 2 receptors. But there hasn't been clear data on that yet. Additionally, the SARS-CoV-2 virus causes an inflammatory response via the innate immune system, leading to lymphocyte and macrophage activation. This can lead to thrombosis with dysregulation of the coagulation system, endotheliitis, and also a cytokine storm. And the cytokine storm then leads to further myocyte injury. And we find that inflammatory markers are often quite elevated in patients who are admitted to the hospital with COVID-19 infection. And it's also theorized that hypoxemia from patients with pneumonia or lung injury could lead to acidosis and oxygen-free radicals that could also worsen the myocardial injury. So what do we know about how these hearts look? So this was a study out of Europe, an autopsy study of 21 adult-aged patients who were positive for SARS-CoV-2, who had cardiac findings. And the interesting thing in this study is that they found that the majority of patients had an elevated troponin. About 50% of them had EKG changes. But lymphocytic myocarditis, which is that classic myocarditis I was mentioning, was very uncommon. It was only 3 of the 21 patients. But instead, there was this profound interstitial macrophage infiltration without myocyte injury that was seen in 86% of the patients. And so they concluded that myocardial interstitial macrophage infiltration was very common with SARS-CoV-2 infection. And so it's not necessarily the same pathophysiology that we would see with a lymphocytic myocarditis and other viral infections. When we pivot now to thinking about the multisystem inflammatory syndrome in children, or MISC, this is the clinical syndrome that resembles Kawasaki disease that is associated with COVID-19 infections. The diagnosis includes a serious illness that leads to hospitalization, typically age less than 21, fever, usually above 38 for at least a day, lab evidence of inflammation, at least 2 organ involvement, and evidence of SARS-CoV-2 infection within the past month. When we look, this is from the New England Journal paper, at these children, what we see is that, so this was a study of 186 children over at 50 centers. So the time from COVID symptoms to MISC is, over 3 weeks. It's closer to 4 weeks, 25 days. The median age of these children is around 8 years, slight male predominance at 62%, and the vast majority of children with MISC were previously healthy. But 80% of these patients do have cardiac involvement. And the really profound things that we tend to see in MISC is an elevated BNP, often in my experience out of proportion to the degree of cardiac dysfunction, an elevated troponin, and actually the majority, 62%, had a normal EF, and only 5% had severe dysfunction. So these children, despite often having lab evidence of significant cardiac involvement with elevated troponins, elevated BNPs, for the vast majority, they do not have severe dysfunction. They may have just normal cardiac function. So again, this seems to be a different process than a lymphocytic myocarditis, or even a little different than what we see in Kawasaki disease. This was another study. There is a lot of overlap between sort of the diagnosis of MISC and heart failure or like COVID-19 myocarditis. So it can sometimes be hard to separate out those two definitions. This is a study of 35 children with heart failure in either COVID-19 or MISC. And so to meet criteria for inclusion in this study was children with fever greater than 38.5 who presented with either cardiogenic shock or an ejection fraction of less than 50%, and they had to be inflamed with an elevated CRP. 88% were COVID PCR positive, and 86% were antibody positive. So they all had a history of COVID infection, and they were on average 10 years of age with no underlying cardiac disease. And this picture just sort of highlights the multi-system involvement. And there's a lot of overlap also with symptoms consistent with Kawasaki disease, which are the ones in red, including coronary dilation and pericarditis, conjunctivitis, red cracked lips, and the lymphadenopathy and rash. But some symptoms that are not as commonly associated with Kawasaki disease, such as shock and the need for VA ECMO and the GI involvement that we often see in MISC. And in these children, the presenting symptoms tended to be fever, weakness, and GI symptoms. 82% of them in this small study were directly admitted to the ICU, and the remainder were transferred to the ICU within 24 hours. 80% were in cardiogenic shock and required inotropes, and 28% required VA ECMO, and all had severely elevated inflammatory markers and elevated troponin and BNP. But interestingly, the LVEF was less than 30 and only 28% of them. So these are children who are in cardiogenic shock with really only moderate systolic dysfunction by echo, and their LV dimensions are normal. The treatment is varied with IVIG, steroids, and sometimes the use of other medications such as anakinra. And the children largely recovered and quite quickly. So the recovery of LV function was observed in 71% of patients at a median of 2 days. So this is acting a little bit different than what we see for a lymphocytic myocarditis, with patients getting very sick, developing cardiogenic shock, but recovering quite quickly without a lot of intervention. This is just a case report of a case of COVID-19 myocarditis, just to sort of give you an example of how these cases can typically evolve. So this was an 18-year-old male, no past medical history, who was admitted with cough, fever, fatigue, and myalgias. Vital signs notable for some tachycardia at 110, a respiratory rate mildly elevated at 22, and slightly desaturated at 94%. PCR was positive for SARS-CoV-2, and the chest x-ray showed peripheral opacities that were consistent with COVID pneumonia. And this patient progressed over 3 days to severe hypoxemia requiring intubation. There was an elevated troponin, obviously, like we don't have the scales here, but very severely elevated troponin, and BNP kind of out of the range that we typically see in some of the other disease processes that are similar, along with elevated CRP, fibrinogen, and CK. The ECG had a sinus tachycardia, and the echo showed diffuse hypokinesis with an LV ejection fraction that was decreased at 30% with just mild LV dilation. This patient required norepinephrine, They did an MRI that was consistent with myocarditis, and they improved rapidly, and the EF was near normal by a week later. And so this kind of shows you just some examples on cardiac MRI of what they see, which is but basically to say that it's consistent with the Lake Louise criteria for myocarditis definition on MRI. So to summarize, we know that myocardial injury is common in SARS-CoV-2 infection in both adults and children, and that myocarditis is relatively uncommon with COVID infection, but other disease mechanisms appear a little bit more frequently, like the inflammation, the cytokine storms. It is difficult to determine the nomenclature between MISC and COVID myocarditis, which makes really understanding this process a little bit more troubling. But typically the treatment for the COVID myocarditis and MISC is generally just supportive measures. I'm going to take a minute to just switch to talking a little bit about vaccine-associated myocarditis. Are there any questions before I do? Okay.
Looks like there's one in the chat.
Oh.
Which I can't find out.
Do different variants cause different cardiac shock findings, and do we need to consider our local variants when evaluating these kids? Good question. I mean, most of this data, there's so little data, particularly on kids, but you know, a lot of is just case reports from here and there. And, you know, most of these studies don't say this was the Delta variant. This is, you know, obviously there's not much on Omicron now, but you know, on the different variants and things. I mean, I think we have seen, because I follow all of our heart transplant patients and that have had COVID infections, and I would say that, like, I didn't have to admit really any heart transplant patients with COVID infection until Delta came around, and then we had a couple. So it may be that things are a little bit different, but I don't think we have found quite so much of a change. Like, we're still seeing MISC in the hospital. We're still seeing some COVID, you know, myocarditis-ish in the spectrum of the MIS-C. So it's not to say that it was really just the first variants that were causing these cardiac sort of involvements and we're not seeing it now, but I don't think we know enough. Any other questions? Okay, I'm going to pivot to talking a little bit about vaccine-associated myocarditis. So as we were learning all about COVID and how it can affect your heart, we slowly started finding out some new information as we began to vaccinate patients across the country. So this started coming out, it's probably in about March and April or so, after vaccines were approved in December for emergency use, and then began getting disseminated. So we started hearing reports of myocarditis following COVID mRNA vaccines, which are the Pfizer and Moderna. And that was like March and April or so that it began to surface. And there are some initial reports from Israel, who were early adopters of the vaccines, and also the US military. And as more adolescents began to get vaccinated, once it was approved down to 16 and then down to 12, we started seeing growing cases in the pediatric population. And this is just a quote from Dr. Matt Oster. He's a pediatric cardiologist at Emory, who is also on the CDC's vaccine task force. And so, you know, these were what we were starting to see is this is young males, especially adolescents, that were in the hospital for a couple days. And we thought, like, this seems like this is right after the vaccine. So is the vaccine a trigger for myocarditis? And so there's a flurry of case reports. So this is the main pediatric case report. And so this was a report of 7 healthy male adolescents who presented with chest pain after the second dose of Pfizer, and they were all diagnosed with acute myocarditis. All were negative for SARS-CoV-2 by PCR, so they did not have active COVID disease. And the majority had fever, so 5 out of the 7 had fever, but they didn't actually meet criteria for MISC. So again, it's not COVID infection, it's not MISC, but they all had very significantly elevated troponins. They were treated with NSAIDs in the majority of them, and then a few were treated with IVIG and steroids, which might be sort of a typical treatment regimen for myocarditis. And in all 7 of these cases, the cardiac MRI showed late gadolinium enhancement that was characteristic. It meets the Lake Louise criteria for myocarditis. All of these patients recovered their symptoms very quickly. We started to see more case reports. This was 23 males in the US military system who received their COVID vaccine, presenting with chest pain within 4 days of vaccine, tended to be younger, median an age of 25, all were previously healthy, very fit, and all had significantly elevated troponin. Of the 8 that had an MRI in this study, all were consistent with myocarditis and all recovered with supportive care. But they noted that that rate of myocarditis in that population was higher than would have been anticipated prior to vaccination. This is another study out of Duke. This was 7 patients that were diagnosed with acute myocarditis by cardiac MRI. And they were all within 5 days of the second dose. They were largely male. I'm sorry, only 4 of the 7 of these in this study were vaccine-associated myocarditis. And they all presented with severe chest pain, abnormal EKGs, elevated troponins. And for the vast majority, the function was normal. So the CDC has been obviously tracking this along with the vaccine adverse events reporting system. And so what they have defined as a clinical case of myocarditis is presence of chest pain, chest pressure, discomfort, shortness of breath, palpitations, and at least one finding of abnormal testing, including elevated troponin, abnormal EKG, an abnormal echo, or a cardiac MRI consistent with myocarditis with no clear other source for your symptoms. Whereas a confirmed case includes an elevated troponin, so it's symptoms plus an elevated troponin and cardiac MRI findings, or biopsy confirmation. But I have not, in talking to any colleagues across the country, have not heard of anyone biopsying any of these cases of vaccine-associated myocarditis. This is some older data now, but this is from VAERS, which is the Vaccine Adverse Events Reporting System, which has been what has been tracking a lot of this vaccine-associated myocarditis. And so out of the number of reports you're seeing, the vast majority are having chest pain, less common to have shortness of breath, often having an abnormal EKG, and almost always elevated troponins. But the amount with abnormal echo is much fewer. This sort of shows you, this is a little bit older data now. We have a couple more cases, but we had a big rush of cases here over at LPCH in the spring into summer as the 12 to 15-year-olds began to get vaccinated. And so you can see that we had 6 of these 8 that had MRIs at this point in time that were diagnosed with myocarditis. Every single one was male. And they were, teenagers. They were just a few days post-vaccine. This one was farther out, but and the troponin was already negative. It had some symptoms earlier on. And all had sort of low normal to normal LV function. They might have had some abnormal EKGs, and their MRI was abnormal. There was a few that had low troponins, but were coming in with chest pain after vaccination that had normal LV function and normal MRIs. Those would not be classified as vaccine-associated myocarditis. So that just gives you a sense of kind of what we tend to see. And so when I talk to colleagues across the country and when you review all these case reports, the presentations across the country are incredibly consistent. So it's typically previously healthy adolescent males. They're coming in 2 to 5 days after the second dose of either Pfizer or Moderna, and they come in with chest pain, often have fevers, and the troponin is often through the roof. They may have abnormal EKGs, not typically arrhythmias, but more some subtle changes in their EKGs with ST changes or T-wave inversions. And their echoes are almost always normal with occasional mild or low normal systolic function. But then when we do a cardiac MRI, we find that they meet criteria for myocarditis. The treatment most commonly across the country has been NSAIDs, although other medications have been used. And some people initially started treating per MISC protocols because that was kind of like our best guess when we first started. Typically people were trending the troponin and then repeating a cardiac MRI and then talking about should we exercise restrict them or not. But when we look at in VAERS, 81% of the patients have had full recovery. So I won't go through every piece of data on these slides. I know they're a little busy, but basically we created a protocol here at LPCH for evaluation of suspected vaccine-associated myocarditis. And so this kind of is the summary of our protocol over the next 2 or 3 slides, and happy to share these with you folks. But so it's, patients that are coming in with chest pain, pressure, or discomfort, typically, or shortness of breath or palpitations, who's within 10 days of COVID-19 vaccination, either dose, although like I said, most commonly it's been after the second dose. And those patients we would recommend evaluation with initially just vital signs and a troponin and BNP, a CRP and an EKG. So not necessarily needing to see a cardiologist right away. And if that evaluation is reassuring, their chest pain could be managed with ibuprofen and followed as outpatients. But if there's any concerns or if the symptoms were more severe, they should either be seen by a pediatric cardiologist or sent to the ER for more urgent evaluation with further testing, including an echo. In anyone who has a positive troponin, we do want to get a cardiac MRI because, as I mentioned, in many of these cases, even when their echoes are normal, their cardiac MRI shows abnormalities. And then in terms of who to admit, we often will admit patients to the hospital if they have an elevated troponin or decreased systolic function. We've had some of these patients admitted to the ICU. We've often just been monitoring their heart rhythm because there has been concerns, but for the most part, there haven't been significant arrhythmias. We've been trending their troponins, and then often we aren't able to get the cardiac MRI when they first come into the ER. So it allows us to facilitate obtaining a cardiac MRI. And we'll make sure that there's not other causes or other reasons why they might have needed or might have cardiac disease, such as underlying cardiomyopathy and family history. We usually just use ibuprofen as needed for symptoms, and we feel safe discharging the patients when they just have a downtrending troponin so that it's not still rising, but it doesn't have to be normal, and that they haven't had any arrhythmias. We might think of placing a Zio patch to monitor their rhythm before discharge, and we'll provide some exercise restriction guidance. So if you had a negative troponin and a normal echo and a normal MRI, then we say you didn't really have vaccine-associated myocarditis. You had a little chest discomfort, but you don't really meet criteria. You don't need to follow up with anyone. You don't need to exercise restrict. But if you have an elevated troponin, but your MRI is negative, we're going to exercise restrict until everything kind of normalizes, and we'll have you see cardiology and follow up because we're worried that you may still be evolving. And then a confirmed case is when you had an abnormal echo or cardiac MRI with an elevated troponin. And in those patients, I'm exercise restricting them for 3 months at least. Typically in myocarditis, we'd exercise restrict for 6 months. Obviously, we think this is a slightly different process, but we do worry that there is still a risk to the myocardium after myocarditis. And Ingrid will get to this in just a moment. So we do want to be careful about letting these patients go back to exercising. So obviously with all of this, it makes everyone really worried about should we even be doing vaccines, right? Why should we do this if there's this risk of myocarditis? But this is just data from the ACIP that basically shows that with vaccination, we're going to prevent, thousands of COVID cases, hundreds of hospitalizations, and some deaths with only a few myocarditis cases. And as I mentioned, the vast majority of these kids with vaccine-associated myocarditis have totally recovered. And this is just the older group showing you like how many cases, hospitalizations, and deaths could be avoided with vaccination with just potentially a few myocarditis cases. This was a recent editorial in Science, because now obviously we're starting to talk about this in the 5 to 11-year-old. So the 5 to 11 Pfizer vaccine is a third of the dose of the adult dose. And in the studies, there was no episodes of myocarditis. And so this just basically says that, myocarditis occurred in approximately 5 of 1 million individuals. And vaccine-associated myocarditis has been relatively mild and self-limited, a fundamentally different outcome from the cardiac effects associated with acute COVID-19 or MISC, which typically involve cardiac dysfunction and require critical care. And so, basically, we would just say that we still continue to strongly recommend vaccination for all patients. So just to conclude, and then I'll pass it over to Inger. So we know that vaccine-associated myocarditis typically presents with chest pain a few days after the second dose of Pfizer or Moderna, typically in previously healthy adolescent males. The troponins and ECGs are often abnormal. Echo is usually normal, but cardiac MRI is often abnormal. And treatment is supportive with ibuprofen as needed for pain. Most with vaccine-associated myocarditis have complete resolution of their symptoms within a few days, and usually repeat MRIs at 3 months show normalization. The risk of vaccine-associated myocarditis is rare. And as I mentioned, there's been no cases in the Pfizer trial in the 5 to 11-year-olds. And we haven't seen any increased risk of vaccine-associated myocarditis in those with underlying heart disease. So we still strongly recommend COVID-19 vaccines to all of our patients. The only exception is if you did have vaccine-associated myocarditis that was confirmed, we would not recommend a second dose or a booster dose for those patients. So with that, I'll stop sharing my screen and pass it over to Inger and any questions that there are.
Okay, are my slides up?
Not quite yet.
Not quite yet. Excellent. Share. How about there?
Yes.
All right, cool. So I'm going to discuss the process of return to play after COVID-19 infection. So Dr. Profita already discussed the incidence of myocardial involvement in COVID-19. We know there's a strong link between myocarditis and sudden death. This is one of the reasons for the protocols for return to play. Exercise is associated with increased viral titers, worsening cardiac function, and increased immune response against the heart. And the risk of sudden death does not clearly correlate with the amount of inflammation. This is an example of a patient who had a moderate case of COVID-19, a 13-year-old football player who had 2 weeks of symptoms, according to the parents and him. He could barely get out of bed for 2 weeks. He lost 40 pounds, but he was not hospitalized. After 14 days, he returned to school and promptly had a deep vein thrombosis. So went back on rest, underwent anticoagulation, and after about a month, returned to school where the PE teacher insisted he do full sprints with the rest of the class on day 1. So he then experienced 2 hours of chest pain and shortness of breath, was evaluated in the emergency room with normal troponin, a normal chest CT that did not show pulmonary emboli, and then in the cardiology clinic where his EKG and echo were normal. So this did not end up being a case with cardiac involvement, but is a nice example of a case that could have gone better with a slow and graded return to exercise. So let's talk about what points to consider in the return to play evaluation. So key questions are: when was the infection? How severe was the infection? And what is the sport or activity being considered? The minimum duration of rest required after COVID-19 infection is 10 days. So patients should not be seen for return to play consideration before then. Once that time period is done, the time differentiation is 3 months. So if the infection was more than 3 months ago and the patient was asymptomatic, mild, or moderately sick, and has already returned to full activity, no further evaluation is required. However, even if the infection was more than 3 months ago, if the illness was severe, the patient requires medical evaluation before returning to play. Within 3 months, all patients require medical evaluation. So not all patients require an extensive workup, however, and that's where the illness severity becomes important. So there's obviously a lot of overlap in illness severity, but this table shows a rough breakdown. Mild illness should be less than 4 to 5 days with general flu-like symptoms. The loss of taste or smell and cough, as we know, can be prolonged symptoms even with mild illness, so they don't come into play when you're discussing duration of symptoms. Moderate illness is defined as more than 5 days, still with no hospitalization, but they may present with symptoms such as shortness of breath, chest pain, palpitations, in addition to the flu-like symptoms. If any labs are obtained during this illness, none should be concerning for cardiac injury. And then the severe illness is defined as anybody who requires hospitalization unless it was a brief, just to make sure hospitalization. Any symptoms concerning for MIS-C fall under the severe illness category, and any lab findings suggesting cardiac injury put the patient into the severe category. And finally, what is the sport being considered? So this question has relevance both for considering the amount of exertion to the recovering patient, as well as the risk of exposure. So in terms of exertion, sports that are considered recreational with a lighter amount of exertion probably require less of a graded return to full participation than competitive sports with higher levels of exertion. So moving on to the guidelines, most of the guidelines stem from these 3 papers. The original recommendations on the left were just for adults and were updated in October of last year to include, among other things, a section on high school students, athletes who they divided into more or less than 15 years of age. In between the 2 adult papers, an American College of Cardiology expert analysis came out from a pediatric cardiologist perspective, which grouped pediatric patients into 12 years and above versus less than 12 years. The age difference in both of these papers is based on the assumption that the younger patients are more likely to be playing recreationally than competitively, so their level of exertion wouldn't place them at the same risk of cardiac complications as older patients. And from that perspective, from a pediatric perspective, the 12-year age cutoff is probably more appropriate. So this diagram shows a rough overview of the return to play guidelines based on illness severity. The pathways for mild here and severe illness are pretty straightforward, but a little more triaging is required for the moderate class in the middle. So mild and straightforward moderate cases can be evaluated by any primary care provider. Anyone with severe symptoms, severe cases requires evaluation by a pediatric cardiologist. Also, mild or asymptomatic cases should not return to play until 10 days after infection, even asymptomatic. Moderate cases also need to wait until 10 days after infection, but should be asymptomatic for at least 7 days. So patients should not be presenting for return to play evaluation until after that point. Note also that the final common pathway for all of these illness severities is a slow and graded return to sports, even for mild or asymptomatic cases. And patients should be counseled that during the return to play period, if new symptoms occur, they should be reevaluated. And part of the reason for this is the fact that MIS-C often presents late and can occur even after mild or asymptomatic infection. So this is a summary of the evaluation recommended by illness severity. While all patients should be evaluated, those who were asymptomatic or had mild illness do not require testing, and so they can be actually cleared by phone or telemedicine. So evaluation, yes, but not necessarily in person. Patients who had moderate illness require in-person evaluation. If the patients are less than 12 years of age and they're planning recreational sports, then they can be screened with a history and physical and don't necessarily need further testing. 12 years and up the recommendation is, in addition to the physical exam, that they have a screening EKG. And then if they have cardiac symptoms or if they have abnormal EKG findings, then they should be referred for a pediatric cardiology evaluation. There is an additional recommendation for elite athletes to consider an echo and troponin. And I'm going to, well, so the severe cases all require pediatric cardiology evaluation and follow myocarditis guidelines for return to play. So the screening questions that should be covered during the return to play evaluation are the same ones that were already recommended by the ACC and AHA in their pre-COVID era 14-point checklist. So the key questions from a COVID, post-COVID perspective are these here, including chest pain, discomfort with exertion, unexplained syncope or near syncope, and excessive dyspnea and palpitations with exercise. The American Academy of Pediatrics has a pre-participation history and physical form, which you can find on their website. The link is here, and I'll show it in my last slide also. The form was updated during the COVID era to include the two questions shown here about, did you have a COVID infection and have you been vaccinated against COVID? The questions on this form do not ask when the infection occurred, so that one you have to ask separately. This is the bottom section of the same pre-participation history form, which includes the questions that cover the 14-point checklist I showed you on the previous slide, which include any relevant questions related to COVID-19. So the questions about syncope, chest pain, palpitations, and then also syncope, near syncope. And then this is the pre-participation physical exam form, which just covers the full exam, the key thing post-COVID being the heart murmur for our purposes. Regarding the screening EKG, there are a number of vague or specific abnormalities that have been reported in COVID-19. And this is just from a study of 63 children who had serial EKGs performed during their course. And they found changes in EKG changes in 42 of the patients. The most common changes, again, are very non-specific, low QRS amplitude and transient T-wave inversions shown here. The T-waves are very flat. And then this is the same patient in their progression, and this is at a post-COVID evaluation follow-up. These last columns do show definite ischemic changes and pericarditis-like changes, which were rare. So sort of the recommendation is any kind of abnormal EKG findings, consider additional workup because it's really not clear whether those are pertinent or not. This is a nice overview of the graded return to play protocol. There are variations, but the general idea is the same. So prior to starting this protocol, patients are expected, in addition to the 10 days post infection and 7 days without symptoms, patients should be able to perform just general activities of daily living without symptoms. Meaning until that point, they should be resting and not exercising. So stage one, once they start the graded return to exercise protocol, you can see it's supposed to last 2 days and is very mild, 15 minutes of exercise for the day and light intensity. And it gives some examples there of types of exercise they're allowed to do. At this stage, the heart rate during their exercise should not increase more than 70% of their normal maximum. Once they enter stage 2, which is confusing because it's day 3, you can see they're allowed to increase to 30 minutes exercise. And as the protocol progresses, they're allowed increasing duration of exercise, increasing intensity of exercise. Until day 7, they're allowed to return to their full level of activity, but they're not supposed to return to actual competitive exercise until day 8, which is when this is done. One thing I wanted to point out here in stage 4, which is days 5 and 6, They are allowed to return to their pre-COVID level of exercise, but only for 60 minutes. The California Interscholastic Federation has a graded return to play form that goes into more detail for each of these stages and is designed to be given to patients. The top section, which is really nice for patients, goes over everything we've already discussed, puts it in writing for the patient about how they need to, if they have any symptoms, go back for reevaluation, etc. The right column of the form also explains the rationale for each stage, so they know somewhat why they're doing it. This form also, once they start into the, so this is the, you need to be able to do daily living activities. Here is where you start your light activity and suggest a medical clearance between stages, days 2 and 3, before you step up the level of exercise. This is not really necessary for milder cases, but is a good idea for the more moderate cases. And then this is just the bottom of the form, which continues the protocol. So it's a nice form. A very brief word about masking. Face coverings are required for all indoor sports unless they've been determined to pose a choking hazard, because indoor sports have the higher risk of transmission. And indoor sports with more players and close contact, like basketball and wrestling, have the highest risk. So the sports that are current exceptions to the masking rule because of the choking hazard are competitive cheerleading, gymnastics, and wrestling, and then water sports because you can't breathe through a wet mask. Band instruments, wind instruments come into this question also, and so there's a recommendation for them in the sports category. However, if the mask can't be worn, then the recommendations are either conduct activities outdoors or perform at least weekly screening testing. And since local authorities are allowed to determine risks of whether masks pose a risk for sports, the California Interscholastic Federation released a statement saying it would be reasonable for any sport to, just not wear masks and perform at least weekly testing. However, masks are recommended at all times by spectators and by players while on the sidelines in locker rooms during transportation, even for outdoor sports. Due to the inability to detect all cases with myocardial injury, youth sports centers and high school sports centers are encouraged to still reevaluate their emergency response preparedness with defibrillators and CPR training and access to emergency medical care. And in summary, so most pediatric patients can be cleared for a return to play without extensive cardiac testing, and the mild cases can just be evaluated over the phone and with telemedicine. However, return to play for all illness severity should be gradual and deliberate. And despite the appearance of full recovery, patients should be monitored during the first month for new or recurrent symptoms concerning for cardiac involvement. And then I'm just going to leave you with this slide, which gives the links for the websites for the American Academy of Pediatrics pre-participation history and exam forms, the CIF return to play form for patients with the protocol. And then if there's any need to refer to LPCH for pediatric cardiology through the referral center, this is the link for that webpage. Thank you. Are there any questions? I'm going to leave this slide up for a moment, but I can also share it with you.
Well, this is Mandy Robertson. That was actually awesome. That was super helpful.
Thank you.
I put in the chat room, just as an FYI, we cannot do cardiac MRIs up here in the Butte County area. I tend to refer down to San Francisco for those, but that's the only point I wanted to just bring up.
That does make it much more inconvenient.
Yes, it does.
So the MRIs, you'll notice in the entire return to play protocol, the only patients who had MRIs required were the ones that fell in the severe category. or during the workup for moderate, there were concerns for cardiac symptoms or abnormal labs that might put them, unbeknownst to us, in the severe category. So that should be a pretty small population of patients who require those.
Yeah, and if you're evaluating someone for vaccine-associated myocarditis, you could do all the other things, such as an echo, EKG, troponin. And if you have ongoing concerns, you could always refer down to our region for a cardiac MRI. I mean, the thing is interesting is that we're finding these changes on cardiac MRI that we're not seeing on echo. They're typically going away, but it does make me worry because of all of the literature of myocarditis. We exercise restrict, and as Ingrid sort of mentioned, all of the concerns around exercise immediately after any heart injury. And so, that's the only thing, is if you kind of didn't know that it was there, because you could get falsely sort of reassured. So that's why I've just been exercise restricting these kids. We also just don't know very much about the vaccine-associated myocarditis. It may be a totally different disease process, but it is still inflammation of the heart that's leading to some damage because the troponins are so elevated.
And then for some of these kids, when the J&J comes out, are you seeing myocarditis with J&J, and can they get a booster with that if they previously had it with one of the mRNA vaccines?
Yeah, so J&J, no, but we also, it's not approved for under 18. So like it may be in the ethos that I don't know about, but everything I have heard is all mRNA vaccine associated. So that's the Pfizer and the Moderna. Because of the efficacy difference between Pfizer, Moderna, and J&J, I think fewer and fewer people that are now getting vaccinated are choosing J&J. Because, and so I think that's kind of the only thing. And then in terms of the boosters, they can, everyone can kind of mix and match boosters at this point. The reason that I'm telling people if they've had true vaccine-associated myocarditis, not just like I had myocarditis for a different reason, but if you had real vaccine-associated myocarditis after a COVID vaccine, I don't want them to get a repeat COVID vaccine. And the reason is that I actually think that they have an overactive response to the vaccine. I think that they probably already have a lot of antibodies that were ramped up with the first dose. And then after the second dose, you're seeing this like strong inflammatory response. So I'm guessing they have mounted a good response to the vaccine and are definitely have protection against COVID. So to add a booster on feels like probably like the risk benefit in those patients. Now that's the current recommendation. That may change, in a year from now if we realize that everyone needs COVID boosters every year or something like that. But that's the recommendation for out of the CDC right now. But the interesting thing is that for the kids that are 5 to 11, we haven't, they're just starting to get vaccinated now, just now starting to get second doses. I am not getting called all the time about 5 to 11-year-olds getting vaccine-associated myocarditis. As I mentioned, the study was a lot smaller. It was only 2,000 patients versus like 40,000 in the adult trials of the Pfizer vaccine. So we may not have been able to detect a signal, but there was not a single case of vaccine-associated myocarditis out of the 2,400 kids who were in the Pfizer trial. And it's a third of the dose. So I think the big question is just like, should we continue to use the full dose in a like skinny 12-year-old or something like that? It makes that conversation harder, but I'm not an I'm not an ID doctor.
Are there any more questions? If so, just remember to unmute yourself. Everybody's pretty quiet. All right, well, it seems.
I have a question, Christy. I'm trying to formulate the scenario here. Maybe you can speak from your experience already. Many of the physicians here with the Medical Society, myself included, have been involved with the pre-participation sports physicals for many years, and we see hundreds and hundreds of kids on particular nights. So my question is this, regarding the big step of committing to clearance for sports by somebody other than their primary care physician, their pediatrician, versus symptoms that might suggest the need for additional evaluation. And the big step is to go on to an EKG, I guess, or laboratory studies. How are you handling that in your clinics, or are you seeing, sorry to ramble here a little bit. I'm just anticipating frustrations that will arise in our clinics in the near future. And getting the appropriate kids to the evaluations that need versus clearing kids that probably don't need further evaluation, but still there's a sensitivity, especially on the part of the examining physician. I think there's going to be concern or sensitivity, risk aversion at making that decision. I don't know. What are your insights?
I just want to make sure I'm understanding the question
Right.
properly.
Yeah. So I guess it basically comes down to a kid presents for the pre-participation physical exam in a mass screening scenario, and symptoms, if they're admitted at all, maybe are mild. That person needs to be sent on to their pediatrician, have some laboratories and an EKG before being cleared.
Yeah, it's sort of, so there is obviously a lot of overlap in the symptoms, and that makes it a little difficult because there's nothing that's going to give you the if here, then here. You know, somebody's going to have some symptoms in the mild and some symptoms in the moderate. So there is a little bit of a judgment call. However, the vast majority of the patients don't need labs at all. Unless you're looking at a patient who had moderate illness and is a competitive athlete over 12. You know, those are the patients who need the EKG. Outside of that, they're not talking about adding labs unless you're looking at a really elite athlete. So most patients are not going to need the labs. The vast majority of the patients, asymptomatic, mild, and moderate, but going to recreational sports, those just need either the phone call clearance and not even, you know, the mild and asymptomatic don't even need the in-person clearance. And then the moderate, but not the moderate patients who are less than 12, who are not elite athletes less than 12, can be evaluated with just the history and physical. So yes, when you get to somebody who's got moderate symptoms, and they are the star, you know, tackle on the football team, and they're 16, then they should at least have an EKG, because every single recommendation, even with the sort of, well, what do EKGs show us? They're very vague and it's not clear. Everybody still recommends them. So there's not really a good clear-cut way to get around that without, if you have a patient who does badly, you're going to get the, you know, what were you thinking question.
Yeah, that's exactly right. Unfortunately, it might scare some of our docs away, but we'll cope with that.
I think, did I also hear that if it's been more than 3 months since their infection and they're recovered, then no further workup needs to be done? Is that right?
Correct. Unless it was a severe infection, if it's been more than 3 months, even if it was a moderate infection, they don't need anything else done.
Hi, I'm Dr. Valdez. I'm a pediatrician, primary care in Oroville. So I, have been following the guidelines, and if I find a kid that has had COVID, go through the questions like you mentioned, how long ago, if they have any symptoms, go through the 14 questions. But what I see a problem is many kids are getting COVID and they're not coming to see their primary care physicians after COVID, even if they're athletes. Is there a campaign at the school level to kind of hold off on these kids to have a clearance before returning to sports, or how is that working in your community?
I have to say I have no idea. I think it's going to vary widely by school, as it always has. I have, I don't have a lot of patients. I've had very few patients who have COVID, other than my own patients who I see who happen to have COVID. But they all have heart disease, and the schools have been very variable in, despite the fact that this patient has known significant heart disease, this school will not require any pre-sports evaluation whatsoever. They don't need a note from me, as opposed to other schools that, won't let them walk down the hallway without a note from me. So it's going to be very variable among the schools.
Yeah, because I think there's a need for maybe, standardize that, if a kid that has a competitive sports has COVID needs clearance by their provider before returning back to school. So that way we can, evaluate the severity, the age, and all the criteria that you mentioned, and then have them return safely. So I just thinking that it's clear for everybody.
And the one key point to remember is, again, this is only for patients who had COVID within the last 3 months. So the patient who had COVID in, February and chose not to see anybody and is coming in for a evaluation in July, they self-cleared.
Yeah, and even now looking at the new form that you presented, I think that's great that they have the last question added, like if you had COVID before, so that way when we can, screen that way, but that's done really like once a year and in the summer. So usually that most cases of COVID are not during that time. So we may clear them, but not necessarily will be safe for the whole year. COVID can happen anytime. So.
Yeah. Yeah, I agree that given the issues with myocarditis and sudden death, and it's, it's not a highly common thing, but it certainly happens. And when it does, it's a big tragedy. So I agree that this is something that that would be much better. Like the patient I showed you, whose PE teacher said, no, you just came back from a really pretty significant case, and now I'm going to make you run sprints. That went very badly. The patient's fine in the end, but was not well handled. And that was despite the parents actually telling the PE teacher that he was really sick. Can you go easy on him? And the PE teacher insisted. So yes, I agree. There needs to be standardization.
And I think it's just, what we always say for our cardiac kids is like, kids should be able to self-regulate, and I know there's a lot of PE teachers who are trying to motivate kids who are a little less physically fit, but it's, how to make sure the kids know how to advocate. And that's also why we worry about the, varsity athletes, because we know they're going to push themselves further than than other people would. They won't stop if they have some pain or discomfort. And so that's the ones that we want to be much more cautious about screening, because we know the level of physical exertion is going to be higher and their willingness to stop is going to be less. So I think those are the ones that we really want to pay close attention to.
Well, if there are no more questions, I want to say a big thank you, especially for sharing those forms. We will probably be doing the sports physicals again in the spring, and having those updated forms is really important. Dr. Philbrandt's all over that. So thank you so much for your presentation today. Unless there's any more questions. Okay. All right. Well, thanks again. And we'll let everybody know that's participating about your CME from Enloe Medical Center. So thanks so much.
Thank you.